Hello and welcome to another exciting online week of policy class. Our topic this week is a very timely one. We are going to be talking about healthcare policy. And that is something we're only going to touch on today, and it's something that we're going to talk about a lot more next semester in the advanced policy class. So what we're going to do today is we're going to speak a little bit about health disparities. We're going to talk about how we pay for healthcare programs in the United States. And we're going to talk about healthcare reform. So healthcare debate centers around some very basic questions, which are a major topic of the current election campaigns. The first one being, is there a fundamental right to healthcare? Is healthcare a right or is it a privilege? Is healthcare something that every human being is entitled to have access to? Or is it something that only people with the resources to purchase it should be able to have as a reward for being higher up in society? The second question is, under what circumstances should people have access to health care? So is health care something that you should have on demand, or is it something that should be rationed, which again is something that we are dealing with in a very real way right now with the current crisis? And the third question is, what level of quality can we achieve at what cost? So what quality of health care can we give people that's worth what it costs us financially in order to provide it? Those are some major ethical questions that are related to who has health care and to what extent they have comprehensive health care. So there are some social determinants of health that lead to healthcare disparities. So health and healthcare disparities, you've heard the concept a lot, but it refers to differences in healthcare, and health outcomes between different populations. Disparities in health and healthcare are related to each other, but they are not the same concept. So for example, a health disparity refers to higher burdens of illness, higher rates of injury, higher rates of disability or disease, and mortality experienced by one group as opposed to another group. Whereas a healthcare disparity can lead to health disparities, but refers to differences between groups in terms of what they can access in terms of healthcare. That could be, do they have access to health insurance coverage? Are they able to actually access care? When they get care, is it the same quality as the care other people receive? Health and healthcare disparities usually refer to differences that can't be explained by variations in health needs, patient preferences, or treatment recommendations. It's also considered health inequality and health inequity. So basically, all things being equal, would these people's health outcomes have been differently if they had had access to better or more comprehensive services or services in the first place? So if you look on the PowerPoint, you will see a map on slide number 5 of health disparities. And if you click on the title, it'll bring you to a CDC report on health disparities. But there are incredible disparities in healthcare and health outcomes in very targeted areas of the United States. Most noticeably, if you look at the map, in areas of northern Texas, Oklahoma, and in the Deep South and along the Appalachians, which of course goes along with the part of the country that experiences the lowest overall socioeconomic status. So if you look at slide number 6, the barriers to healthcare amongst non-elderly adults by insurance status, this was only not even 2 years ago. So if you look, people who were uninsured, who did not have health insurance, 52% of them said that they did not have health care. They did not engage in any health care. So when you think about not engaging in any preventive health care, that means that people could have health conditions that have been festering in them for years and only finally receive health care at a catastrophic moment, like a stroke or a heart attack or cancer. Then you could see that 27% of people without insurance postponed seeking care due to cost. 21% went without any needed care due to their cost. And 19% postponed or did not get medications because of their cost. Those are incredible numbers, and those are overall numbers of the United States public. So there are a number of factors that contribute to escalating medical costs. Access to medical care has definitely increased with Medicare and Medicaid and employer-based coverage. So some of the factors are third-party financing, that is private and public insurance. Self-pay and employer-sponsored health insurance premiums are astronomically high. I mean, I can tell you for me personally, my employer, the state of New York, pays 80% of my health insurance premium, and I'm still out of pocket over $400 a month for health insurance. So when you think about it, we're talking about health insurance for myself and my husband, if we were to pay out of pocket, costing well in excess of $2,000 a month, whether we utilize services or not. You have a rapidly growing number of older people, and as we know, when people do get older, they experience more health needs and more acute health needs that result in a need for more medication. Medications can be very expensive. And as you're seeing what's happening in the current crisis, they're saying that older Americans, older people, are going to be more likely to need higher levels of healthcare and intervention during this pandemic. So when you think about it, those elderly people, even in terms of what the cost of treating them is going to be on average much higher than most younger people who become ill. There are advances in medical technology that are fantastic, but advances in medical technology come with a huge price tag that is then passed on to the insurance company and ultimately the patient. Medical facilities are constantly expanding. Litigation is a major issue that contributes to high cost of healthcare. Litigation being the high cost of medical malpractice. We live in a very litigious society where people, more so than any other culture, are more likely to engage in lawsuits if something medically does not go the way they think it should. And doctors, nurses, all health practitioners pay incredibly high fees for malpractice insurance to guard against lawsuits. The overall cost of healthcare and inflation, the cost of a hospital, the cost of paying physicians, administrative costs, what it costs to process insurance claims, and then finally the pharmaceutical industry, which we've talked about in class. Medications can cost an absurdly high amount. When you think about it, something like insulin can cost people out of pocket hundreds of dollars a month for something that they need to keep them alive. So the alternatives are either don't pay for your insulin and you die, or you pay for insulin and you can often live in poverty. So when you look at Medicare, most recipients of Medicare is an entitlement program. Most recipients are age 65 or older. They're usually receiving Social Security retirement benefits. Some younger people will qualify for Medicare. Those can be the people on SSDI, so those are people that have been disabled for at least 2 years. It also covers people with end-stage renal disease, meaning kidney failure, and people who are blind. And that is a social insurance program. It's not a public assistance program in any way. If you work a job, you pay into a Medicare fund. It is in no way contingent upon income. It is something you automatically get when you are 65 years old. Right now, about 35 million recipients of Medicare benefits are elderly. About 6 million are disabled. Each year, we spend about $281 billion on Medicare insurance. And as there are more and more baby boomers who are aging into that population, that cost is only going to go higher. So within the Medicare payment system is Medigaps. And again, we'll talk more about this next semester, but Medicare only pays for a certain amount of your treatment, and then you are responsible for an amount out of pocket before Medicare will pay any more money. And then the other issue is the need for long-term care. Again, as people are getting older and older, they're going to require, if they don't have families that are going to take care of them, if they don't have in-home caregivers, they're going to need plans later in life for where to live and how to stay safe. So you're going to see more and more elderly people who need nursing homes, who need long-term care facilities. And those facilities, again, are extremely costly. My father-in-law until recently was in a long-term care facility with a cognitive disability, and his treatment, thankfully he had long-term care insurance, but between that, his Social Security, and payments that my mother-in-law were making, it was running almost $12,000 a month. to keep him in the long-term care facility. And that's not one of those fancy high-end assisted living homes. This was a nursing home with a memory unit, not high-end, not fancy. So those costs go up and up all the time as well. And people who don't have long-term care insurance and don't have other assets, Medicaid and Medicare are going to end up having to pay for them to be in those long-term care facilities. So let's talk about Medicaid. Every state operates their own Medicaid program that are funded through block grants from the federal government. Medicaid is the most expensive public assistance program. In 1970, so again, 50 years ago, Medicaid cost about $5 billion. In 2015, Medicaid cost $521 billion. So the federal government pays its share of Medicaid costs from the general tax revenues, and then the states use their own revenues as well to fund Medicaid. Poor states get more money from the federal government, with all states getting somewhere between 50 and 83% of the money they spend on Medicaid from the federal government and tax money. Every state has its own rules and regulations and policies to administer their Medicaid program. Each state determines how much they will pay Medicare providers for the services that they give. And most physicians will not participate in Medicaid treatment because those reimbursements are so low, and it takes a very long time to get reimbursed through Medicaid. Technology has helped. The fact that you can now do Medicaid claims online instead of having to do paper forms, but it takes a long time, and what they pay is not very much. So Medicaid is for people who are aged or disabled. Most SSI recipients will receive Medicaid. Children and their parents, children can be on the child health insurance plans, which again, each state has their own child health insurance plan. It's for medically needy, and through Obamacare, there was something called the PPACA, which was a Medicaid expansion that states could opt to take or not take. Surprisingly, most states in the South and a number in the Midwest declined to take the Medicaid expansion just because it was part of the Affordable Care Act or Obamacare. So nationally, Medicaid is comparable to private insurance in terms of access and satisfaction for the patients. Medicaid is not perfect. It's a lot better than being uninsured. Uninsured folks have much worse outcomes than people with Medicaid. So if you click on the graph on slide 11, that will give you some more information about that. If you look on slide 12, benefits of the Affordable Care Act for Americans. Now, the Affordable Care Act, a lot of people don't even really know what it did. What it did was it improved quality and lowered healthcare costs for most Americans. It provided a lot of protections. It provided access to healthcare for people who previously had no access to health insurance. One of the major things that the Affordable Care Act did was that it removed the clause that allowed insurance companies to either deny coverage or increase premiums for people with pre-existing conditions. And again, as we will talk about next semester, those pre-existing conditions are many. And I would wager that most of the people in this class, myself included, if the pre-existing condition clause still existed in insurance plans, none of us would be able to have insurance. So it provided insurance for vulnerable women. It provided insurance for young adults under their parents. So many of you are probably feeling the benefit of that. It extended coverage so that parents with a child, even a child in college, I believe it extended coverage to 26 years of age under the parents' plan. It strengthened the Medicare program, and it helped to hold insurance companies accountable for both their reimbursements and for the level and efficiency of care that they were willing to provide and what they covered. So from 2008 to 2018, the percentage of U.S. adults without health insurance has gone down. When we talk about the uninsured, those are people without health insurance. So just because people are uninsured, it doesn't mean that they are adequately insured. You can be underinsured, meaning that your health insurance plan exists, but the means to use it are so out of reach that you may as well not have health insurance. What is the point if you are somebody who is, middle to low income? What's the point of having a health insurance plan if you have $15,000 deductible? That means you have to spend $15,000 on your health care before your insurance plan will cover anything. Let's say you have to go into the hospital for a procedure. Let's say your procedure costs $10,000. How good is it to have a health insurance plan if you have a 30% coinsurance? Meaning that if you go in for a $10,000 procedure, and $10,000 doesn't buy you that much in terms of medical care anymore, that's going to cost you $3,000 out of pocket. You may as well not have a plan at all, except for maybe astronomical circumstances. So there's a direct relationship between education, income, and insurance. Poor people tend to have less access to education, which means that you're less likely to be insured. Most people get insurance through private means, mostly through their employer. Employer-sponsored group health plans are less insurance than if you're buying them by yourself because you're spreading the risk out. So while the Affordable Care Act was not perfect, it gave a lot of people access to relatively affordable insurance that they did not have before. We are still in the midst of the Republican government trying to do away with the Affordable Care Act, even in the midst of the pandemic, which is just shocking to me. So right now, if you look at slide 14, if you look at the current eligibility for ACA coverage amongst the non-elderly insured by race and ethnicity, that will show you the number of people from different ethnic groups that are depending on the ACA and subsidized healthcare in order to have access to insurance. So then if you look at the next slide, slide 15, the characteristics of the non-elderly insured in 2018. Shockingly, people think that everyone who's uninsured are primarily Black people and Latino people. 41% of all people in 2018 with no insurance who are not elderly were 41%. So some of the reasons for being uninsured amongst the non-insured non-elderly adults, 45% said they cannot afford their insurance. So 45% of people without insurance said, it's just not possible for me. 21% said that they lost their jobs or they changed employers. Now keep in mind, a lot of times if you take a new job, you then have to wait a certain amount of time before you're eligible for health insurance. When I was working in Texas, my first 4 months on the job, I was not eligible for health insurance. Then if you lose your job, a lot of times you could do what's called COBRA, which is sort of extending your coverage for, I think it's up to 2 years now. However, if you take COBRA coverage, in most cases, you have to pay the full cost of your plan. So for myself and my husband, it would be $2,300 a month out of my pocket to continue our health insurance until I had another plan in place. 13% of people said that it was because they lost Medicaid. That could either be because they were just out of reach of the Medicaid threshold, which again, for a family of two is roughly $19,000 a year gross. Or it could be because they were unable to recertify for any number of reasons. 10% was because of some other status change. 9% was because their employers just don't offer health insurance. And only 3% said they didn't think they needed health insurance. So just to summarize here, I want you to think for a moment. Remember we talked about, is health insurance a right? Is health coverage a right, or is it a privilege? I want you to think about, when we talk about disparities, think about what's happening in the healthcare system right now. When we talk about the potential to have to ration healthcare, when we talk about having to decide, if you've read the news, having to decide who is worthy of life-saving medical intervention. Saying, well, if people are over a certain age, if people have certain kinds of conditions, if people have some kind of lifestyle, they are less worthy in the moment, in a crisis situation, of access to life-saving medical equipment than somebody else, somebody who's younger, somebody who has a different body type, somebody who does not have certain health conditions. There are reports now saying that there are triage plans in place that people with certain cognitive disabilities, people with certain developmental disabilities, that they would not be given preferential access to life-saving medical equipment in the case of extreme need. That's a problem. The fact that right now we are in essence having to decide, amongst the medical community, who is more worthy of life-saving medical intervention and who's making those decisions. So I want you to think about that. So in summary, lifestyle and genetics are primary factors related to health outcomes. Age and income are primary factors related to health disparities in this country. Medicaid coverage is for the poor. Medicare is for the aged or the disabled. The Affordable Care Act, which is still under attack, was designed to help reduce healthcare costs and improve access to care by mandating participation in the health insurance market. And the new current administration has and continues to systematically work to strip away parts of the Affordable Care Act that has provided life-saving health insurance to tens of millions of people in this country. On that note, I hope you are all doing well. I hope you're healthy. I hope you're staying sane and safe and washing your hands. And hopefully I'll see you all soon. Bye.